The reason that we're interested in polyhydramnios is that it results in increased perinatal morbidity and mortality. Now, perinatologists are always looking to try to identify high-risk groups. This is their bread and butter. Perinatologists deal with high-risk pregnancies. And here is a typical example of a high-risk pregnancy. Polyhydramnios increases perinatal morbidity and mortality. Now, if I were to ask you to list the 3 features which increase the likelihood of a poor outcome with polyhydramnios, I'm sure that after a very short time of reflection, you would come up with the right answer. So you would say, more oligohydramnios is worse than less oligohydramnios. True. If it starts early in pregnancy rather than late in pregnancy, it's probably going to have an increasingly poor prognosis. True. And that the faster it came on, the more likely it would have a poor prognosis. Also true. So these 3 factors, easily thought through using simple logic, tell you who is more likely to have a bad outcome. Now, if we actually look at the definition of polyhydramnios, we find it's greater than 1,500 cc's of amniotic fluid at or near term. This is useless to us for a variety of reasons. As sonologists, we can't use a static definition of at term. We're obligated to make judgments about amniotic fluid volume throughout pregnancy. We can't wait till 40 weeks to make a decision as to whether or not what we're looking at is polyhydramnios. As well, we have absolutely no way of actually predicting how many cc's of amniotic fluid are in the amniotic sac. We can only estimate it. Indeed, we can see among these 105 fetuses that we studied with polyhydramnios, and I will refer back to this study in a number of slides during this lecture, you can see that in fact you can see polyhydramnios from the beginning of the 2nd trimester all the way through the end of the 3rd trimester. Now, these were the earliest sonograms at which polyhydramnios was diagnosed. Therefore, someone in this group may have actually occurred at this time, but a sonogram wasn't done at that time during pregnancy. Nonetheless, you can appreciate that the time that polyhydramnios is most likely to be seen is at the end of the 2nd trimester and running through the bulk of the 3rd trimester. This is when we tend to see it most commonly. Now, as we said, the static definition of 1,500 cc's is useless to us. So, it's a rather remarkable statement that I'm about to make. But if you want to know what polyhydramnios is, it is what you say it is. So when you pick up the dictaphone and the word polyhydramnios comes out of your mouth, all of a sudden, this is a case with polyhydramnios. Now, hopefully, you weren't sitting there bored that day and thought to yourself, I haven't said the word polyhydramnios in quite a while, so I think I'll dictate that in this particular report. Obviously, there's something about the look or the measurements of the amniotic fluid that made you suspect that this was a case of polyhydramnios. And in fact, there are 3 mechanisms that have been described for the sonographic diagnosis of polyhydramnios. We are going to start with the second one on my list, which is called the 8 centimeter rule. Now, this was a rule that was originally described in a paper by Chamberlain and Manning. Now, Frank Manning is a very well-known maternal fetal medicine specialist and ultrasound specialist who worked this out, where he said you measure the deepest vertical pocket of fluid that you can identify, and if it's 8 centimeters or more, that constitutes polyhydramnios. Well, to be perfectly honest, even though I have a great deal of respect for Dr. Manning, when I read his paper, I thought to myself, Frank has gone off the deep end here. There's absolutely no way this complicated fluid that we see insinuating here and around this structure and around that structure, take one measurement and you can decide whether there is or is not polyhydramnios, made absolutely no sense to me. However, I will admit, he did his study on a large number of patients, well over 7,000 patients, and using the criterion of 8 centimeters, 243 of them, or 3%, turned out to have polyhydramnios. Now, in medicine, as you know, normalcy is usually described by plus or minus 2 standard deviations. Well, 2 standard deviations on either end of a bell-shaped curve excludes 2.5% of the patients. 95% of patients are contained within 2 standard deviations. So 2.5% and 3% were really pretty close, and I certainly could understand his desire not to make it the 7.85 centimeter rule or the 8.21 centimeter rule. Those would not make sense, and a nice round number was the most appropriate thing to recommend. Well, as I said, I thought that Dr. Manning had definitely gone off the deep end, and Dr. Ruth Goldstein and I decided we were going to prove that he was wrong and publish our results. So we were big believers in the visual estimate of amniotic fluid. So we did the following study. We took a large number of patients where we looked at our visual estimate of amniotic fluid. Now, when we did our visual estimate of amniotic fluid, we allowed ourselves to say it was oligohydramnios or polyhydramnios. By the way, Chamberlain and Manning also described the so-called 2 centimeter rule for oligohydramnios, so they were the originators of both the 8 and the 2 centimeter rule. So we either scored them visually as oligohydramnios or polyhydramnios, or normal. But in the normal group, we allowed ourselves to say it was normal but below average, or normal but above average. Then, 3 months later, we came back. We had large field of view images of the entire uterus, and we measured the single deepest vertical pocket depth we could find on the sonogram, and then created this chart. And I have to say, I was remarkably surprised to see how perfectly linear this chart was. Even greater in terms of surprises was that neither myself nor Dr. Ruth Goldstein had called any case oligohydramnios that had a pocket diameter greater than 2.5 centimeters, and neither Dr. Goldstein nor I ever called a case polyhydramnios that had a pocket diameter less than 7.5 centimeters. So there was almost a perfect correlation with what Dr. Manning had thought was an appropriate means of judging fluid. Now, you'll notice that this is rather broad compared to the other ranges in the graph. But that, of course, is because here you can only be 0 to 2. Here you could be 8. Well, my current record is 22 centimeters. So you could be anywhere from 8 to 22 centimeters in diameter. The last one is the one that is probably most commonly used today, which is the amniotic fluid index. I am not a big fan of the amniotic fluid index. This is a notion, in my opinion, wherein someone says if one measurement is good, then 3, 4, 5, 6, or 7 measurements necessarily must be better. That is not true. Nonetheless, there have been very few measurements I've seen in obstetrical sonography that have taken the obstetrical community by storm, more so than the amniotic fluid index. It's almost like it was chiseled on stone tablets next to a burning bush. Well, let's look at the amniotic fluid index. As you probably are fully aware, since you, I'm sure, do this measurement, there's a range of normal. Now, I happen to use 5 to 24 centimeters for normalcy, with oligo being less than 5 centimeters and poly being greater than 24 centimeters. But there are all kinds of notions as to what the upper and lower limits are. There are also graphs that allow you to do it by date. Again, there's no conceivable way that anything I say now will stunt the use of amniotic fluid index. As you know, what the amniotic fluid index does is exactly the same thing as Manning proposed to measure the deepest vertical pocket, but instead of simply measuring the deepest vertical pocket, you measure the deepest vertical pocket in 4 quadrants of the gravid uterus. Now, what are some of the reasons I don't like the amniotic fluid index? Okay, you know what the rules are. You measure the deepest vertical pocket in an AP dimension without cord or small parts in the 4 quadrants, add them together. That's the amniotic fluid index. I can follow those rules absolutely precisely by measuring the deepest vertical pocket right there, then move over to here and measure it again, then move over to here and measure it again, then move over to here and measure it again. I have followed every rule of measuring the amniotic fluid index, and it's totally ludicrous. Now, the thing that really bothers me about it is that while you may never have thought of it quite that way, intuitively, every sonographer understands that that doesn't make any sense whatsoever. To basically measure the same pocket 4 times 2 millimeters apart. It's ridiculous. And the knowing of how ludicrous that is drives all the measurements out to the periphery, which is no more logical than measuring them all right here. So, a word to the wise is sufficient. Don't be a slave to the notions that you must go out to the edges of those 4 quadrants to measure the deepest vertical pocket.